This vlog is part of a comprehensive educational program on using HIV-ASSIST as an educational resource for selecting ART in patients with HIV. You can obtain downloadable slides on the Clinical Care Options website, as well as gain CME, CE, or CPE credit by viewing this vlog.
My name is Maunank Shah, and I'm an associate professor in the Division of Infectious Diseases at Johns Hopkins University. In today's talk, we're going to review how one can use the HIV-ASSIST tool and incorporate it into the decision-making process to guide antiretroviral therapy modification in an individual who had an undetectable HIV-1 RNA. I'd like to share with you this case of a patient that was 49 years old was diagnosed with HIV in 2014. He had a history of unstable housing, but was currently living with his son. He'd been virally suppressed on his original regimen of rilpivirine, TDF, and FTC, but was later switched to dolutegravir and rilpivirine in 2019 due to declining GFR and for a desire to avoid any kind of impact of tenofovir exposures. He'd remained virally suppressed on this regimen, but over time had begun to express some pill fatigue. He had type 2 diabetes that had been previously poorly controlled, but with increasing control once he had initiated long-acting insulin, along with metformin and other oral agents. He also had moderate hypertension, which was reasonably controlled on lisinopril and amlodipine, though there had been some consideration for adding a third agent as well. He also had chronic kidney disease, as I mentioned, which led to the switch to dolutegravir and rilpivirine a few years earlier. At a recent visit, he expressed a few items. The first was a desire to reduce pill burden, even though he was already on a single tablet regimen. He also noted that now that he was living with family with whom he had not yet disclosed his HIV serostatus, that he was nervous about the potential for an accidental disclosure if his medications had been discovered. So I wanted to share how the HIV-ASSIST tool might be used in this scenario to try to inform decision-making around possible ART modification strategies. Here you see a snapshot of the HIV-ASSIST tool. In this instance, one would indicate that the person is on dolutegravir and rilpivirine and virally suppressed, has no history of resistance mutations, noted by the blank box at the top where mutations can be entered. The comorbidities can be entered as well, along with the co-medications, and the tool will assess drug-drug interactions. I'll next walk you through the HIV-ASSIST output. Here is a snapshot of a broader output page, which ranks all possible 2, 3, 4, and 5 drug combination regimens. In the base case scenario, the regimens are ranked according to a composite HIV-ASSIST derived weighted score, which I'll review in a moment. But on this output page, the tool seeks to also provide other pieces of important information, including the number of active drugs, and importantly, the pill burden and dosing frequency. This HIV-ASSIST weighted score is a composite score that seeks to try to maximize likelihood of viral suppression while also trying to maximize tolerability. Lower scores are preferred. Overall, the way the tool works is by assessing mathematical penalties when there are regimens that have increasing pill burden or for which there are side effects or likely drug-drug interactions. The tool applies a relatively low score when there is evidence for being able to achieve virologic suppression in the context of the inputs that are provided. So let's walk through this particular output that was provided for this set of patient considerations. What you'll notice is that most of the regimens that are shown on this slide have a relatively low weighted score. What that means is that each of these regimens have fairly strong evidence for being able to maintain virologic suppression, as well as being tolerable. That's not surprising since the person is on a single tablet regimen and seems to be tolerating the medication without any notable side effects. However, you'll notice that his current regimen of dolutegravir and rilpivirine shows up a little bit lower than some alternative options. When one clicks on dolutegravir rilpivirine, an education sheet is shown along with the annotated rationale. In this case, what you see is the step-by-step rules that are applied by the system to derive this final score. In this instance, this regimen starts with a very favorable score of 1 because they are already virally suppressed on a regimen that appears to be well tolerated. However, you'll notice that the system assesses a minor penalty because there is a drug-drug interaction between dolutegravir and metformin. The tool derives this information from both the DHHS guidelines as well as the University of Liverpool's HIV drug interaction checker. In this case, it notes that the usage of dolutegravir can increase the AUC of metformin by almost 80% when they are co-administered. While this is not a particularly major interaction, the presence of any interaction as well, of any kind, will cause a slight mathematical penalty to be assessed. And in this way, regimens with fewer drug interactions will bubble up towards the top of the output that are provided by the tool. But let's shift gears and take a look a little bit more closely at one of the other regimens that is also recommended in this particular instance, and that's the regimen of cabotegravir and rilpivirine, which is at the top of this list. The DHHS guidance has recently been updated to include long-acting cabotegravir and rilpivirine as an optimization strategy for people with HIV who are currently on oral antiretroviral therapy with documented viral suppression for at least 3 months. The recommendations have a number of additional considerations that must be considered and that are actually factored into the tool's outputs as well. Notably, the recommendations suggest that this regimen is a reasonable option for consideration when there is no history of baseline resistance or virologic failure, and the person does not have concomitant active hepatitis B, are not pregnant or planning to become pregnant, and that there's no significant drug interactions. All of these elements are actually factored in by the HIV-ASSIST tool. But importantly, the tool also seeks to provide much of this DHHS guidance directly at the point of decision making. So notably, when one clicks on the cabotegravir rilpivirine regimen, you're taken to an educational information sheet. This is just a snapshot of that particular education sheet that is provided for the cabotegravir rilpivirine regimen, but it includes an editorial overview which summarizes some of the guideline information and practical considerations. The educational sheet also provides information about recommendations for treatment naive and treatment experienced patients, as well as clinical trial data, which I'll come to shortly. There are a number of reasons that one might consider an antiretroviral therapy switch in a person that's already achieved viral suppression. Some of those reasons are summarized here from the DHHS guidelines. Notably, in the most recent iteration of the guidelines, there's additional provision that one may consider switching to a long-acting injectable regimen for the reasons of pill fatigue or to try to reduce potential stigma associated with daily oral medications. Both of these reasons are part of the decision-making in this particular patient's case and are reasons why a long-acting injectable regimen might be a reasonable option for this particular patient. And this just shows, I think, a good example of how we must, as providers, be cognizant of individuals' changing considerations and to always be reassessing what is in the best interest of our patients for long-term durability of virologic suppression. There are a number of studies that support the usage of long-acting cabotegravir and rilpivirine, which are summarized here. As I mentioned, part of the goal of the HIV-ASSIST tool is to try to make primary literature and evidence available to clinicians in an easily accessible fashion. From that same HIV-ASSIST education sheet that I showed on the prior slide, here you see another section of that informational content, which includes a summary of some of the key clinical trials that provide evidence for the usage of cabotegravir and rilpivirine. In the ATLAS study, individuals who were already on stable antiretroviral therapy and virologically suppressed were randomized to receive either cabotegravir and rilpivirine or to continue their baseline antiretroviral therapy. The FLAIR study was a little bit different in that it enrolled antiretroviral therapy naive patients who had no history of hepatitis B and had no resistance mutations outside of a K103N. These individuals were randomized to a 3-drug oral ART regimen of dolutegravir, abacavir, and 3-TC, and if achieving virologic suppression, were eligible to be randomized to the cabotegravir rilpivirine regimen or to continue this oral antiretroviral therapy option. In both of these studies, the investigators sought to first start with an oral cabotegravir rilpivirine regimen, primarily to assess tolerability, before switching to the long-acting injectable regimen, primarily because the long-acting injectables have fairly long half-lives. Here you see the outcomes of this study at 48 weeks. Both studies had very favorable outcomes with regards to both the primary endpoint of virologic failure and secondary endpoint of achieving viral suppression. In both studies, the long-acting injectable cabotegravir rilpivirine regimen was non-inferior to the oral antiretroviral therapy comparator. It's important to note that there is now follow-up data out to extended durations, and this regimen has been shown to be quite durable, even out to 96 and 124 weeks, with very few additional reported virologic failure events. In the ATLAS extension study, also called the ATLAS 2M, the investigators evaluated a strategy of using Q4 versus Q8 week dosing and found very favorable results. And consequently, at least in the European context, a Q8 week dosing has now been approved. However, in the US, the FDA indication and the DHHS guidelines still recommend Q4 week dosing, but it's just worth knowing about this additional information because recommendations may change in the future. There has also now been data to suggest that a direct to inject strategy that skips the oral lead-in phase may also be acceptable, and guidelines may in fact change in the coming future with emerging evidence. One of the ways in which the HIV-ASSIST tool can assist providers, particularly when it comes to these new regimens that we may not be as comfortable with, is by providing dosing information. When one clicks on the cabotegravir rilpivirine output regimen, in addition to the education sheet, one can click on the dosing information tab, which provides information including renal and dosing and any changes that are needed in the instance of liver disease. In this particular case, there are no dosing adjustments that are required, but I did want to just highlight that because this person did have chronic kidney disease. The instructions for administering cabotegravir and rilpivirine are quite specific, which we'll go into in the next few slides. Notably, there are very specific considerations with regards to the oral lead-in phase in the current package insert, followed by initiation and loading dose and a maintenance dose, as well as considerations for how to approach missed injections. Additional information that's summarized on the HIV-ASSIST tool includes information about side effects. And one of the things to just note about this particular regimen is that injection site reactions have been extremely common in more than 80% of individuals. But most of instances, this is relatively mild, and it does seem to abate over time, particularly once you get to the maintenance phase with lower doses. In the clinical trials, only 1% of individuals discontinued therapy because of the injection site reactions. So let's review some of the practical considerations with regards to cabotegravir and rilpivirine dosing. Currently, the FDA indication and the DHHS guidance recommends using an oral cabotegravir rilpivirine lead-in phase for 1 month to assess tolerability. This is followed by an initial loading dose of 600 milligrams of cabotegravir and 900 milligrams of rilpivirine, which equates to a 3 milliliter injection that is given as 2 separate gluteal injections. The volume of injection does subside over time, such that after that initial loading dose, subsequent doses on a monthly basis are only 2 milliliters, but it does still require 2 gluteal injections, one for the cabotegravir and one for the rilpivirine. When one is considering initiating these new long-acting injectable regimens, it's important to stress the importance of adherence to a fairly strict dosing schedule. In the event that an injection is planned to be missed by more than 7 days, providers should work with the patients to establish a plan to initiate a oral bridging therapy, which can be used to replace up to 2 consecutive monthly injections. When there is a planned missed injection, the first oral dose should be given about 1 month from the last injection and continued all the way until the day the new injection is resumed. On the other hand, when there's an unplanned missed injection for more than 7 days, one of the first things that should be done is to reassess the appropriateness of this long-acting injectable regimen for the patient. Now, assuming that it's deemed that it's still clinically appropriate to continue this regimen, the injection should be resumed per the package insert recommendations as soon as possible. Now, the strategy for resumption depends a little bit on how much time has actually elapsed from the prior injection. When it's been less than 2 months from the prior injection, you can resume at the continuation or maintenance phase dosing schedule of cabotegravir 400 milligrams and rilpivirine 600 milligrams. However, if there has been a prolonged interruption such that there's been more than 2 months since the last injection, one reinitiates the loading dose initiation injection, which is a slightly higher dose and volume. This is then followed by the monthly maintenance doses of 400 milligrams and 600 milligrams, respectively, for cabotegravir and rilpivirine. Coming back to our patient, after reviewing all of these considerations, including the need to adhere to a strict injection schedule, as well as providing educational information about the injection site reactions, and the strategy of oral lead-in followed by the injections, the patient did choose to make the switch towards the long-acting injectable cabotegravir rilpivirine regimen. So I think a few of the take-home points for this particular case are that there are a number of valid reasons to consider regimen modification in the setting of viral suppression. In some instances, this can be because of pill burden or pill fatigue, or even to reduce stigma associated with antiretroviral therapy. I hope I've been able to demonstrate a little bit about how the HIV-ASSIST tool can be helpful to you in your clinical practice. One of the goals of HIV-ASSIST is to bring together a number of clinical resources to help clinicians in the ART selection process. In this particular instance, I think the tool was particularly helpful to provide easy access to guideline-related content, as well as primary literature and information about drug-drug interactions for consideration of a fairly new regimen that many of us don't have a lot of experience with. Thank you for joining me today, and I hope you've gotten a flavor of how the HIV-ASSIST tool can be useful to you in your clinical practice, and I hope you'll check out the HIV-ASSIST, which is available freely at www.hivassist.com.